Hello, judges. My name is Dr. Dhiraj Shah. I am a second year internal medicine resident at St. Vincent Hospital, Worcester, Massachusetts. I am presenting a case of renal limited lupus like nephritis. We have a 55-year-old Hispanic lady who presented to the emergency department with left upper quadrant abdominal pain. It started 2 weeks earlier and was gradual in onset, increasing in severity, radiating to back, and worsened by movements. She denied nausea or vomiting, did not endorse bowel or bladder symptoms. 3 months earlier, she was admitted for unprovoked pulmonary embolism and was started on apixaban, then switched to rivaroxaban due to side effects. Her other comorbidities include hypertension, scleroderma, and unspecified interstitial lung disease. Review of system was negative otherwise. On examination, vitals were normal. Left upper quadrant abdominal tenderness was present. Lab showed WBC of 11,000. HNS was 10.8 and 33.3. Platelets was 294,000. Urine analysis showed mild hematuria and nephrotic range proteinuria. CT abdomen was done, which is demonstrated in the slide showing left renal vein non-occlusive thrombosis and bilateral renal infarcts. She was admitted to the medical floors for further assessment. On day 2, she developed both upper and the lower extremity weakness. Brain MRI showed watershed infarction, raising the concern of thrombotic phenomenon, likely due to cancer. Lymphoma was high in our differentials. In pursuit of those possibilities, a chest CT was done, which showed mediastinal lymphadenopathy, and follow-up biopsy showed reactive lymphoid hyperplasia. The question was yet to be answered. What is causing nephrotic syndrome leading to thrombotic phenomenon? Nephrology was brought on board and they agreed with our plan to get a renal biopsy, which showed diffuse thickening of capillary walls due to deposition of subepithelial immune complex, which we can see in the slides. And immunofluorescence microscopy showed strong stain for IgG. Finally, we had our answer. She had class 5 lupus nephritis, which by new guideline is sufficient for the diagnosis of systemic lupus erythematosus, with or without serological marker. In our case, only ANA was positive. She was started on mycophenolate mofetil and prednisone and switched to warfarin for anticoagulation. Lupus limited to kidney is a rare entirety. We have 39 reported cases of adults with renal limited lupus-like nephritis. Most of them presented with typical nephrotic syndrome. 7 had proteinuria and hematuria. None of them presented with renal vein thrombosis or pulmonary embolism. As per the review article published in Canadian Journal of General Internal Medicine, among 39 cases, 17 patients had reported outcome, among which 47% had poor outcome leading to early hemodialysis. So early diagnosis with high suspicion and intervention is important, which slows the progression of disease. This is one of the take-home messages, and another is anticoagulation in lupus is still debatable. The use of direct thrombin inhibitors and factor Xa inhibitors has not been studied in patients with nephrotic syndrome, whereas experts feel warfarin should be started and continued as long as patients remain nephrotic with serum albumin less than 3 gram per deciliter. The goal INR is 2 to 3. Thank you for giving me this golden opportunity.